Welcome.
Good afternoon, sir.
Sir, Sunko sir, can we start?
Yeah, please go ahead, sir.
So,
Let Dr. RSV say
yeah.
whether we are live.
RSV, can we?
We are live on YouTube. Over to you, Dr. Sridhar.
Yeah. I welcome all the doctors and all the delegates and all my faculty team for today's World Obesity Day webinar. Today on March 6th, 2025, we observe the World Obesity Day, a global call to action to address the growing epidemic of obesity. So, you know very well, obesity is the major health concern that affects millions of people. As per the latest statistics, it is 2.8 million deaths annually because of the obesity, leading to the other serious health conditions like heart disease, stroke, and diabetes, and health certain types of cancers. So, there is a call to action on this day. Most of the children, because of the COVID era, we passed on to the COVID era, more obesity cases are seen. And there are few key messages where our faculty will be giving on healthy lifestyles and early intervention and support to environment and reducing the stigma. So these are the things where we will be. And our panel, I request today's our president, PATS, Sunkoj Bhaskar sir, to address the audience and the delegates and start the event, sir, today's webinar. Please.
Thank you, Dr. Sridhar. And good afternoon, our esteemed faculty, Dr. Sri Nagesh, Dr. Shreya Sharma, Dr. Anjaya, and Dr. Shekhar. As well, I welcome our IAP executive members, Dr. Lakshman Garlapati and Dr. Rajshekhar Rao, along with all the other participants. My special thanks to Dr. RSV for taking interest in organizing this meet. I appreciate his efforts. And as you all know, today, that is, though it's not the 4th March, but on 4th March, we celebrate this World Obesity Day by the World Obesity Federation. And it's a global problem, it's a global crisis, not just a developing country or a developed country. It is there across the world. And if we do not take some action right now, after 10 years, 25% of the population is going to become obese. And 100% of the children, whatever rate is there, it doubles by another 10 years. So it's an emergency. And to tackle this, we need to act collectively. That's the reason why they celebrate this World Obesity Day, to create awareness among the people and as well to sensitize and stimulate the healthcare professionals. I'm so happy all the esteemed faculty members, they give us valuable opinions about obesity, how we should sensitize the people, how we should sensitize our parents. And together, it's not only we, it's mainly the government and NGOs, like of course IAPs, other societies should act collectively and to educate the society and to do some advocacy and as well some policy changes by following junk food nearby schools and educating the parents about the harmful effects of the increased salt, sugar, fat in junk foods. And also the physical activity should be taken into serious action, like having physical activity. When I was a child, way back in 60s, every day we used to have physical education for at least 1 hour in open grounds under sunlight. So some physical activities at school, at home should be there. And as well, the screen time is a very, every one of us and children are addicted to the screens. It should be curtailed. So these are all the things. Unless we do, our children, our next generation across the globe will suffer. So I appreciate IAP taking this, Central IAP taking this obese day very seriously, involving our pediatricians to do whatever best to our children to keep them healthy. So with these few words, I thank and I do not want to take much time on this. And I request Dr. Sridhar and Dr.
Yeah.
Our RSS Sri Krishna to conduct the proceedings.
Yeah.
Thank you, one and all. Jai Hind.
Thank you, sir, for your nice words about the World Obesity Day. Now I request Lakshman Garlapati, sir, our Central IAP member. You know very well our active member. Raj Shankar is also there. I request Lakshman Garlapati, sir, to say a few words on this occasion, sir.
Yeah, thank you, Dr. Sridhar. Yeah, and this is on behalf of Central IAP. I congratulate PATS team for conducting this webinar on this Child Obesity Day. Today, as we pediatricians would like to raise the awareness about obesity, its health impacts, and the collective action needed to address this growing global challenge. Today, through this webinar, we hope to discuss preventive strategies, treatment options, and policy approaches. And we have excellent lineup of panelists with us, Dr. Shreya, Dr. Anjay sir, Shekhar sir, and Dr. Nagesh. Let us dive into this webinar, and I hand over to Dr. Sridhar again.
Yeah.
To
Thank,
take
thank,
proceedings further.
thank you, sir. Now I request Dr. Rajshekhar Rao to say a few words. Rajshekhar
Good
Garu.
afternoon, sir. Good afternoon, sir. I thank the PATS President, Secretary, and Treasurer for taking the initiative of starting this exclusive webinar on obesity as it is central IP program. As you all know that obesity is becoming a bigger problem, as President sir told. Recently, I heard that when Ash Reddy sir today only that 60% are overweight in our in Hyderabad and 30% are obese. And out of that, 40% of the children are non-alcoholic fatty liver in school children. Today only sir was telling Dr. Nagesh Rao. I thank the panelists, today's panelists, two endocrinologists, Dr. Sri Nagesh and Shreya Sharma, and two senior pediatricians, Dr. Anjay sir and Dr. V. Shekhar sir, will enlighten on obesity. Thank you for giving this opportunity. Thank you, sir.
Thank you, Rajshekhar. So we'll straight away go for this today's World Obesity Day exclusive webinar. And I request Dr. R.S.V. Sri Krishna moderate the today's event of webinar. And also I request welcome all the panelists, Dr. Sri Nagesh, who is the pediatric endocrinologist from Hyderabad, and Dr. Shreya Sharma is a pediatric endocrinologist from Dehradun, and senior most pediatricians Anjay Gaud and Anjay Kundu, and also V. Shekhar. He's also a pediatrician from Mehboob Nagar. I request RSV, please take over the stage and please introduce all the panelists also. Okay, thank you.
Thank you. Thank you, everyone. At the outset, namaskarams and warm greetings on behalf of IAP Telangana State Chapter. And it's a pleasure for me to introduce the esteemed panelists talking about obesity. We have at the forefront the opening batsman as Dr. Sri Nagesh, who is a son of our own soil. He is a pride of Hyderabad, and he is a DM endocrinology, having done MD pediatrics from Hyderabad. We also have gold medalist from AIMS, Dr. Shreya Sharma, who has recently finished her DM endocrinology from there, and also MD pediatrics from JIPMER. And we have two outstanding pediatricians who are exemplary in their own field for advocacy for childhood fitness. Dr. Anjay Gundu, his name is given for the first ever badminton trophy conducted by IAP, TCB, and PATS. We're very thankful to him that he is an ambassador for fitness amongst all the pediatricians and strongly supports fitness as a mode of even treatment for children. We also have Dr. Shekhar. Dr. Shekhar is a very close friend and has been the torchbearer for Para Olympics, and he is the president of Para Athletes Foundation, Federation of Telangana State, and one of the competitors in last year's competition has won the Arjuna Award thanks to all the support and mentoring of Dr. Shekhar. So we have two pediatricians who are not just but ambassadors for fitness, and two endocrinologists who are here to answer multiple questions that we have on this theme of obesity. The webinar is more still because there's a lot of talk now on obesity and what needs to be done. Before I start, there are a couple of astounding numbers. One, apparently the numbers of childhood obesity are increasing, and we don't know why exactly. And it is a problem not just limited to children. They have this problem as they grow and they become obese adults and suffer from a lot of lifestyle related diseases. Thirdly, this problem needs a big solution. In fact, you need something as big as COVID was just for a couple of months and years and went off. But this problem of obesity will stay for many years to come. So this is something that we need to tackle. And rightly, the theme has been on changing behaviors and also strengthening our health systems. Without that, I don't think we'll be able to make big change, and these numbers will just keep growing. So to start the innings, may I now request Dr. Anjaya to please tell us the definition of childhood obesity. We'll start our discussion from there and delve deeper into other aspects of childhood obesity. Over to you, Dr. Anjaya, to please tell us the definition of childhood obesity. Yeah, Dr. Anjaya, sir, please go ahead. Anjay sir, can you hear us? Other panelists, is my voice clear?
Yes, sir, it's clear.
It's clear. Dr. Anjaya, if you're there, to please respond. Not very sure why he's not able to hear us. Okay, Sri Nagesh, you are our default batsman for any such crisis. So please let us know. Yeah, Anjay sir, you can hear us now?
Back online.
Sri Krishna, some network problem.
Yeah, Sri Krishna, network problem.
Sir, please go ahead, sir. Anjay sir, please tell us the definition and then we'll pick up the discussion from there.
Yeah, good evening all. I'm delighted to be one of the panelists for the webinar on the childhood obesity. And at the outset, my heartfelt thanks to the PATS President Sunkoj Bhaskar and Secretary Dr. Sridhar and Treasurer and the moderator Dr. Sri Krishna. Are you able to hear me?
Yes.
A simple definition of obesity is a chronic disease that occurs when there is an excessive amount of fat deposition in the body. In children, obesity is categorized on the basis of body mass index, that's BMI. In children about 2 years old, if the BMI is equal or more of 95th percentile is defined as obesity, and the BMI between the 85th and 95th percentile fall in the group of overweight. Over to you, Sri Krishna.
Thank you, sir. Dr. Sri Nagesh, is this the same definition that you use for adults as well? Number one. Second, what is the role of the much hyped waist circumference? Do we not use that in case of children? Because these values, what Dr. Anjaya spoke about, is all on percentiles. So what is the difference in the way in which we define it for children versus adults? Second, what is the role of the waist circumference?
Yeah, in children, we actually look at percentile charts, but when it comes to adults, we generally focus more on the BMI, absolute BMI values, which I personally feel is for the West, overweight is anything more than 25, whereas for Asians, it is usually anything more than 23 kilograms per meter square. And anything more than 25 kilograms per meter square in Indians would be defined as obesity, whereas it is anything more than 30 in the Western population. But I feel this is actually a very imperfect way of looking at BMI, because somebody with a big muscle mass, which contributes to the weight, can have a large BMI. And it's more important to focus on centripetal obesity, especially the waist circumference, which is quite significant among the Indians. In my personal opinion, generally, I have always, more than the waist circumference, I've given more importance to the waist height ratio. Any waist height ratio more than 0.5 is something which is considered obese. or somebody who's at risk of obesity and the future problems of insulin resistance and obesity. This was actually part of my dissertation topic, where I actually correlated this with skin fold thickness, body fat analysis bioimpedance, and markers of insulin resistance, especially adiponectin, visfatin, and the serum insulin levels. And any waist height ratio for the Asian population more than 0.5, especially in a child, I would consider them obese or at least at risk of obesity.
Just taking that forward, Srinagesh, how do you measure body fat then? Because even now you're telling me it is body mass index and also a ratio, but I am looking at just fat. How do you measure fat?
Body fat, the best method of looking at body fat is by doing it via densitometry, whole body densitometry. But this is not practically done. It is an expensive and it is a bit labor intensive because most places you do not have body fat DEXA analyzers. But generally, you can even go in for surrogate markers like waist height ratio if you have got validated data. And we do have some validated data for Indians. Or secondly, you can actually look at the newer bioimpedance devices. If you use it in people who are more than 11 years of age, a lot of the newer bioimpedance devices actually give you a very good analysis of body fat, provided you do it in somebody who's beyond 11 years of age. They're validated only beyond 11. Electrical bioimpedance.
So very useful insights. Now taking it forward, Dr. Shreya, what are in general the causes of pediatric obesity? Now that we know how to measure it, and now we do a measurement, and we find that some of them are obese indeed. Now, what are the causes? And please stress upon the non-endocrine causes from your end, and we'll take the discussion from there.
Right. So as we know, as in adults, even in children, the exogenous, we would sort of categorize it into two: exogenous and endogenous causes of obesity. So the exogenous cause of obesity in children is also predominant. So approximately 95% of the cases, even in children, we would find would be exogenous obesity, which means that is lifestyle related and just a sedentary lifestyle and a wrong sort of a diet. And but in those cases where we so in the exogenous obesity, we would see a pattern in which the child is obese but is also tall, so that their linear growth is normal and they have a normal pubertal advancement, and they also have normal development. So there is no such red flag in that case, and they're all tall children. So along with the weight increasing, the height also increases in tandem. But in other cases in which we see there's associated short stature, or if there is delayed development, or if there are any neurological features or any syndromic features, or there is any hypogonadism per se, in those cases we have to suspect other causes of obesity. So I'd like to underline those causes as well. And the first being the monogenic causes of obesity. So here we would have very early onset obesity. Approximately before 5 years of age, the child will start gaining excessive weight. And it would also be more or less associated with hyperphagia. So it would be a very food-seeking behavior that we would get on history. And also there could be some other pointers like reddish hair or adrenal insufficiency in certain monogenic obesity cases like POMC syndrome, or in POMC gene mutation. Or then we can talk about the syndromic causes of obesity, which could be the Prader-Willi syndrome or the Bardet-Biedl syndrome or Alstrom syndrome, to name a few. And then there is also obesity which can be due to exposure to drugs like corticosteroids or antipsychotics or anti-epileptics. And then there could also be a hypothalamic obesity, which could be due to any neurological insult or CNS lesion, which is causing an insult to the hypothalamic lesion, again causing the hyperphagia, and again this could lead to obesity. So that we would need neuroimaging in these cases to if we suspect hypothalamic obesity. And I think the last would be the endocrine causes of obesity. So those would be hypothyroidism or growth hormone deficiency or pseudo-hypoparathyroidism and Cushing's syndrome. These are the 4 causes which we generally keep in mind. So these would broadly be the causes of obesity in children.
Thank you, Dr. Shreya. So that brings us to the syndromes that you had just mentioned. Dr. Srinagesh, when do pediatricians suspect that this is probably a syndromic obesity? What are the pointers? And how common are these? And what is the importance of picking them up early?
Yeah, when you actually look at syndromes, I divide syndromes into 2 main types. One is the monogenic variants, and the second one is the monogenic disorders, and the second one are the classic syndromes. syndromes many a time would actually come with typical features. For instance, if you have Lawrence-Moon-Bardet syndrome, they will have polydactyly, they will be obese, there will be some amount of visual disturbance because retinitis pigmentosa is classically seen in these disorders. Most of these disorders will present with hypogonadism. This is very commonly seen in Alstrom syndrome, Cohen. Dysmorphic faces is classically seen in Carpenter syndrome. In almost all the syndromic disorders, the other classical thing like Shreya has described is if it is an exogenous obesity, the excess of energy will actually drive their vertical growth as well as a horizontal growth. So in case they generally tend to be obese but not very tall, in the setting of dysmorphism, and if there is a history of consanguinity, but this is not always mandatory, that is when we actually need to suspect the syndrome and refer it appropriately to the endocrinologist. And also you will need a geneticist help in this because diagnosing syndromes is a bit difficult, and a proper diagnosis of a syndrome helps us not only predict about the obesity, but also the future complications of these disorders, because some of them can be associated with visual issues. Some syndromes can actually have coexisting cardiac disorders. Many of them, pseudo-hypoparathyroidism, for one thing, can actually present with hypocalcemia, present with short stature and other problems associated with obesity. And all of these can, to an extent, be predicted if you can do a proper genetic evaluation of these disorders.
Thank you. Thank you, Sri Nagesh. Just coming back to Dr. Shreya. Shreya, how do we distinguish a child who is growing is chubby or obese? I know we are looking at BMI, but is there a way in which we can pick it up early, especially in certain families where their families have been slightly on, I would say, they're not obese, but have a different body proportion. So how do we distinguish this? And is there anything else that we have to pick up from history? Because BMI and others are only on measurement. Is there anything that can come up as a complaint which can be attributed to obesity as a diagnosis?
Right. So in terms of history, so it's very, very important. Again, if if you want to know the cause of the obesity, and especially if we are suspecting endogenous causes of obesity. For example, if we get the history that the child has been gaining excess weight before the age of 5, that is not normal because generally a child will not. We do not expect a child to overeat before 5 years of age because generally it's on demand, and it's only the influence of the family and the lifestyle generally starts after the age of 5. So that's sort of a rough age at which we can sort of keep 5 years as the threshold. And if it's after 5 years that the child has been becoming excessively obese, then we can still think of an exogenous cause. But if before that, then we have to think of an endogenous cause. The other history we have to take is of the birth weight. And then we have to ask about the onset and progression of the obesity, of course, and how rapid it has been. Then we ask about the history of hyperphagia. So again, nocturnal eating, like getting up in the night seeking food or eating the leftover food of others. So sort of a food seeking behavior, that history we have to ask. And then we also ask about the developmental history, very important, because the syndromic causes and the monogenic obesity causes, and even in the pseudo-hypoparathyroidism, we may find a delayed development. Again, in hypothyroidism, we may get a delayed development. So there, the developmental history becomes very important. And then, of course, like in Prader-Willi syndrome, if we ask about the feeding history in in infancy, so in the first 2 years of life, in a child with Prader-Willi syndrome, they will have they have a lot of feeding difficulties. They may even require rice tube feeding at times. They don't have a good suck initially, and it's a paradox that initially they have failure to thrive. And then they start gaining weight after 2 to 3 years of age. That is the time when they start gaining weight, and then they develop obesity. So this pattern is also very characteristic of Prader-Willi, which is one of the common causes of syndromic obesity that we see. So these are the pointers from the history, apart from hypogonadism. But of course, hypogonadism is a clinical finding that we must always examine at least a male child for testicular descent, and whether the test size is appropriate for age or not, and whether the pubertal development is happening, depending on what age the child has come to us for review. But if we find there's a delayed development, there's hypogonadism, there is cryptorchidism of any sort, then we know that there may be associated hypogonadism here. And then again, the endogenous causes become more important. The exogenous cause may not be what we are actually looking at. So these are the pointers from history, and of course in clinical examination, if we go ahead to clinical examination, then we are looking at polydactyly or visual issues, and we are also looking at dysmorphic faces, and then in pseudo-hypopara we can find these short fourth metacarpals and metatarsals. In Prader-Willi we get these almond-shaped palpebral fissures and very short fingers, acromicria it's called. And so these are the sort of soft pointers, I would say, that give us a clue towards the diagnosis. But when you say chubby versus obese, I think we have to be very objective in terms of getting we have to see the weight for height for a child less than 2 years of age. For more than 2 years, we do the BMI, and then we look at the centiles as Dr. Sri Nagesh has described, and we can also do the waist height ratio. So I think there we can have a very objective measure, and from the history also we can get that. So yes, we can, and then of course we look at the family history. Yes, so family history for obesity, the diabetes, any metabolic issues in the family, all of that also we take into account.
If I might add one more point to what Shreya has said, there is something known as a Dykens hyperphagia questionnaire. This has recently been developed, especially for very young children who have hyperphagia, because the kind of hyperphagia actually gives you a clue to the diagnosis of what disorder also they might have, even if it is monogenic or Prader-Willi. For instance, the Dykens questionnaire ranks very high in people who have leptin and leptin receptor gene mutation. Slightly lower down the order. Classic hyperphagia is described at around 5 to 6 months of age in somebody with MC4R mutations, which are the commonest cause of monogenic obesity. And like Shreya has put it, children with Prader-Willi, at least initially in life, will rank pretty low on the Dykens questionnaire. But as they age further, the hyperphagia increases. Just doing a simple questionnaire can give you a clue as to not only whether the patient has a monogenic or a syndromic obesity, but also what kind of obesity it is most likely to be, so that we can corroborate it with the clinical, endocrine, and the genetic markers which we do.
Yeah, thank you, Dr. Srinagesh and Shreya. Now, Srinagesh, this question I'll have to put it to you. This is something we've been talking for the past 2 days, and the video clip by Dr. Nageshwar Reddy has created more conversations around it. First of all, why are there more obese children now? See, as a percentage, has it always been like this, or are the kids of 2010 2020 more obese than what we were when we were as kids? And we hear this term secular trend in SPM. Is that in force? Number one. First question. Second question, is the Hyderabad's biryani to blame for it? Is it that we are not physically active? And very strangely, if you look at the NFHS 5 data, Kerala ranks top in terms of prevalence of obesity. We talk about literacy, education, we all talk about this. So many more in Kerala are perhaps aware of the dangers of obesity, and their diet is perhaps not as bad as elsewhere. Why is all this slightly disturbing for us, and what are the probable reasons behind? One, the rising trend. Second, how Kerala is having the highest prevalence of obesity, and what role does lifestyle have in the emerging trends on obesity?
I'll answer the biryani question first because it's very easy. Biryani has been around since 1620. So I don't think it's contributing to obesity. We've had almost 500 years of, 400 plus years of biryani. The first part, rather than tell you the reasons, I'll give you a typical example of the life of a child in Hyderabad today. They get up at around 7:30, have their breakfast around 8:15. A typical patient who comes to me with obesity goes to the school by 9 o'clock, finishes school by 3:30, 4 p.m., comes back home at around 4:15, 4:30, has a snack, goes for his tuition classes till 6:30, then goes for his coding classes till 7:30, 8:30. Some people go for their painting classes, come back home around 9:15, have their dinner at around 10 o'clock. Now, where do you have the time to exercise in this regimen? So who is to blame? Is it the parents who are to blame, or is it the children who are to blame for this? And a lot of people are in foundation courses for IIT, foundation courses for NEET, foundation courses for everything, including the civil services from 7th to 8th class, starting from 8 a.m. in the morning till 10 p.m. at night. So do we really expect these children to exercise at midnight? I don't think that's possible. And with this kind of a regimen, if you don't have an obesity, what else are you going to have? This is not just a secular trend. This is actually a man-made trend. Until and unless we have this we get rid of this penchant of parents ensuring that the children are part of the rat race and including them in training for everything, leaving them with very little playtime. And most of the time, these kids are so tired that on Sunday, they're likely sleeping. And as all of us know, fast food, junk food, unhealthy carbohydrate-based food has actually come into existence, has been there for a very long time, and this is not going to change. That has not changed much over the past even 15 to 20 years. But what has changed is the amount of time which was actually being dedicated towards physical activity. As some of our senior faculty were telling, they used to have physical activities every day. As Dr. Bhaskar was telling, they used to have 1 hour of physical activity every day. Now, if you get in 1 hour of physical activity every week, your child should consider himself lucky. In this scenario, I don't see anything else other than what is happening right now. Unless parental attitudes change, school attitudes change, and the public perception of physical activity changes, we are not going to have a relief in the obesity pandemic. And the third question, why Kerala has such a large extent of obesity? This is a socio-economic and socio-cultural question. For instance, the diet of a typical Kerala person is very difficult from the rest of South India. They have more of parboiled rice. It's been proven many times that parboiled rice has a fair amount of carbohydrate content. The amount of satiety, there have been multiple studies on this. Satiety with boiled rice is much more than what is classically seen with parboiled rice. They tend to eat more of carbohydrate. Tapioca is very widely consumed in Kerala. And again, this tapioca contributes a lot to the amount of obesity we see. In fact, even MASLD, metabolically associated steatotic liver disease, is much higher than in the Kerala population. For many years, this is actually attributed to the use of coconut oil, which is the main medium of cooking in Kerala. Recent studies have to some extent challenged this, but we do not have any conclusion. But again, saturated fat does increase your cholesterol levels and also your hepatic deposition of fat. Thirdly, if you look at the typical social picture in Kerala, a lot of these people tend to work abroad. They work abroad for a decade or two. Many of them actually are from the lower economic strata who go to the Gulf countries, tend to have a slightly inexpensive diet, which is more in carbohydrate and less in protein. Work for around two decades, then retire permanently, come back, have a life of inactivity, which again contributes to the obesity, which you classically see in this population. And alcohol consumption is also fairly high. It's fairly high across India, very high in most of the South Indian states. It's also high in Kerala. So I generally think, and because of the increased prosperity, the use of mechanical devices and the use of other aids has increased in Kerala, and physical activity has come down. There is very little amount of walking, even though you have excellent beaches in Kerala. They just don't make use of them. So all these factors put together, I think, have what contributed to the increase in obesity in Kerala. If you actually look at the statistics from the other South Indian South Indian states, we are not very far off from Kerala. Kerala is around 25, 26. The other South Indian states are at 22, 23. It's just that they are the highest, but we are not very far behind them.
Okay, thank you. Thank you. Very interesting insights. Thank you, Sri Nagesh. Just last point before we go to prevention. You spoke of two different aspects. One is diet, the other is exercise. I know both of them have their effect, but is one compensating for the other? Question one. Second, exactly biochemically, whatever way you can explain to us, how does a bad diet or a lack of exercise, how exactly does it over a period of time cause this obesity?
Obesity, diet and exercise are not exclusive of each other. We have to understand that the contribution of diet is much more, irrespective of the age. The contribution of diet is much more than what is seen with exercise. Basically, if you do not have exercise, your metabolic rate, once you start eating less to ensure that you have a weight loss, your body tries to compensate for the decreased metabolic intake by cutting down on the metabolic expenditure. And when you exercise, it prevents, to put it very simply, it's a lot more complex than that. But basically what it does is it helps you essentially to reduce this energy saving, which is done by the body. When you exercise, it prevents your body to some extent from doing this energy saving, so that irrespective of whatever you eat, even if you cut down eating, you tend to spend more energy. As far as what is the determinant of a diet, especially a high carbohydrate diet is concerned, in adiposity is concerned, this is again very complex. We don't really know the complete underpinning of this, but basically what happens is when you tend to have more carbohydrate, your insulin sensitive lipase levels go. When you have more carbohydrate, more insulin is secreted. This insulin mediated lipase levels increase. And what it does is it converts most of the energy in which you have taken into the triglyceride form and ensures that it is stored in your adipose tissue. On the other hand, when you have a diet which is less in carbohydrate, this was actually the basic linchpin of what is called as the keto diet. When you took in more fat and you took in less carbohydrate, your insulin levels decrease. So the insulin sensitive lipase levels go down, whereas the hormone sensitive lipase levels increase. And what these hormone sensitive lipase levels do is they break down your adipose tissue and liberate more of the triglycerides and free fatty acids, which are then used by the body in lieu of carbohydrate, which is in short supply. If your body cannot use glucose, it will use more of this fat, free fatty acids and triglycerides and the ketone bodies. And generally, as your adipose tissue starts breaking down, you tend to lose more of your weight. But the problem with using this kind of high fat diets is, even though they appear very attractive in basic understanding, in addition to the fat loss, you also have significant chunk of muscle loss. Before the body starts breaking down your fat, it also breaks down your muscle. So there is a large amount of sarcopenia. And secondly, there is a significant amount of dehydration. And some studies, we do not have any long-term data on these diets. A few studies have shown us that they have cardiovascular benefits. At the same time, a few studies also have shown us that there can be some amount of cardiovascular problem. And eating a diet rich in saturated fat might increase your LDL and also some amount of plaque deposition. So without any clarity on these diets, the most important thing is these diets are not sustainable in the long term. You can stay with a less than 10% or a less than 15% carbohydrate diet for a month, 2 months, 3 months, but not more than that. And most important for most of us, people who are listening to this debate and people who are speaking in this debate, the evolution of man from chimpanzee and gorilla was actually said to be because we started having a high carbohydrate diet, cut down on our fat, took in more carbohydrate, the brain thrived on carbohydrate, and we branched off from the monkey. So we don't really know if we keep having a keto diet for a long period of time, we might regress back to the monkey.
Thank
So
you.
all
Thank
these
you. This is
factors,
very, yeah. So this is
better
very
we stay with
exciting. I think
a
we'll
reasonable
need
diet.
a separate session just to discuss the effect of diet. And there's so much science, so much of insights on how the food that you eat defines the person that you are. Thank you. Now we'll quickly move on to prevention, and who better than Dr. Shekhar to tell us on the broad principles of prevention in childhood obesity. Over to you, Dr. Shekhar.
Hello.
Yeah, please go ahead.
Yeah, hi. Good evening, all, and thank you, Sri Krishna, and thank you, PATS, for giving this opportunity. Yeah, well said, Nagesh. And this is, I think, this is a very good topic to. I'm able to audible.
Yeah. Yes.
So this is a good topic to discussion for the discussion. Okay. So as rightly said about the by the Nagesh, the school schedule and the child's day routine is completely packed with the so many. I mean, other than sports is packed completely well packed. So I think it is the prevention is has to be taken in a different levels. It has to come from the parent, from in a house from the parent, because the parent has to be should be a lead example, and they should be a role model to the fitness. And second thing is they should have some nutrition education for the parents, because most of the parents, they think giving processed foods and sugary drinks and unhealthy snacks is a prosperity or expression of love. So they do keep doing that. So, and they come with a they'll be putting so much hard work ducks up. So we give what they ask. So, or some of the big schools, they the kids will be given pocket money, and you can find them outside the school in any restaurant. I mean, I'll be seeing some kids in near Manikonda. They'll be sitting after the school. They'll be sitting and having all the processed foods. So it's one thing. So this healthy eating habits has to be come from the parents. And second thing is it has to be the increased access to nutrition food has to be there, because see, we keep on talking about the fruits and vegetables and whole grains, but the availability, access and availability is comparatively like that is protein-rich foods and everything is little difficult to find which is healthy, which is not healthy kind of things, because mostly we were thinking we'll be talking about on organic or non-organic basis, bias they'll be taking I don't think they'll be taking good nutritional foods. And when I speak to kids and other parents, they'll be like having a school canteens where they'll be providing pizzas, burgers, biryanis. So that is one of the affluent school health system where that has to be regulated. So if and more things like the parents, this sports and outdoor activities has to be encouraged in schools, because as I said, Vinagre said, there is no PET period or physical education period in our schools, because most of the schools are not having any school grounds or playgrounds or anything. Like if they have PET period also, they'll be using for some extra other activities.
Yeah, I think we just lost Shekhar's connection. Shekhar, you're there? Yeah, I think he touched upon some very important points which are related to the family staying as a joint ambassador for the child's health. It's not enough if you just counsel the child on what to do and you end up doing exactly the reverse of it. So it's something which the family has to own up and then do it. Yeah. Thank you, Shekhar. Now we'll move on to the point which you mentioned on the diet. And there's a popular concept of 5210. Dr. Anjaya, if you can please tell us what is this concept of 5210?
Okay, thank you. Obesity prevention guidelines from American Academy of Pediatrics recommend that is to fight childhood obesity. The rule is 5210. The 5 denotes the 5 servings of fruits and vegetables per day. 2 denotes reduce screen time less than 2 hours a day, and 1 hour for moderate exercise or sports or games indoor outdoor. And 0 denotes zero consumption of sugar sweetened beverages. Over to you, Sri Krishna.
Yeah, thank you. Now we're coming to, so we discussed the causes, the approach, then we looked at the prevention, and diet forms a very important step in prevention. Now we're coming to management. Straight, simple questions to you, Dr. Sri Nagesh. What is the role of medications in handling childhood obesity? I'm talking about the non-endocrine, non-syndromic causes. Second, what is the role of surgery, if any? Third, what is the role of alternative medicine? Because now that is as popular as mainstream allopathic medication. Is there any role which you are aware of, any medicine that works in Unani, Ayurvedics, or any other alternative medicines in the management of childhood obesity?
To answer the first question, as far as non-syndromic obesity in children is concerned, for the medicines, we have 2 main contenders. The first one is Orlistat, and the second one is GLP-1 receptor agonist. Both liraglutide and semaglutide have both been recommended in pediatric obesity. But no medicine can be advised in children till 12 years of age. The lower limit for starting any medication in children is 12. I have used Orlistat in a few children and the results have been very disappointing. One, there isn't a huge amount of weight loss. And second, children don't tolerate Orlistat all that well. Even with a very low dose of 60 mg, majority of the children have complained of severe stomach pain and socially inappropriate diarrhea, especially in the school setting. I would not recommend Orlistat in somebody unless and until they are at a situation where they have adequate recess to go to the washroom in case they have diarrhea, which is not always possible in schools. I'm not a huge fan. I use Orlistat, but I'm not a huge fan of Orlistat in children. Molecules like liraglutide and semaglutide have been tried in children over the age of 12 years. They have been tried in teens. They have been approved, and the newer molecules also. Some trials are currently being done in children, but even today, I would actually say that in non-syndromic causes of obesity in children, I would first prefer a therapeutic trial of lifestyle and exercise. Because whenever you start any medication for obesity, you have to understand that obesity is a chronic disease. So once you start medicine, the big question is how long? Are you going to continue this medicine for the rest of their life? It is extremely unlikely. It's too expensive, and we do not know what the long-term consequences of using these medicines are. So never use them until and unless as a last resort. Even if you use them for a short period, whatever weight loss you've got has to be maintained by lifestyle. There is an over reliance of GLP-1 agonist. Too much interest has been expressed in Ozempic and Wegovy. I do consider it an unhealthy trend, especially in a child. As far as bariatric surgery is concerned, again, bariatric surgery has many long-term consequences. There is a significant amount of bone loss, loss of vitamins. There are a lot of other problems, and weight regain is also very common. In syndromic causes, especially mineralocorticoid receptor 4 and leptin and leptin gene mutations, where it is not hyperphagia is too much and it is not possible to control the child by conventional means. You can actually setmelanotide is a new molecule which has been used except in all the other variants except MC4R, but it is expensive and not widely available. And if you think obesity is causing life-threatening complications, then you can go ahead with bariatric surgery. But again, this is only in the teens or after they've completed the teens. And you'll have to watch out for all the other complications of bariatric surgery. And weight regain is a definite, it's a certainty, it's not even a possibility. You should be prepared for that. The third and the easiest part, I have no idea about Unani and these other alternative medicines. Many people have told us a lot of things, but we will stick only to what we have studied in our textbooks and for which there is evidence-based medicine. Especially in a child, I think it's dangerous prescribing non-evidence-based medication.
Yeah. So you told us so many molecules and said it doesn't work. Let me add one more, metformin. Do you want us to write?
Metformin, I would not recommend for obesity. I've seen many people using metformin I've seen a lot of pediatricians, some people doing serum insulin levels in an obese child and prescribing metformin. If you're obese, obviously your leptin is going to be high, your insulin is going to be high. If you check for insulin in this kind of a child, you're just wasting the parents' money. He has acanthosis. It is understood that he has high insulin levels. And a lot of times using metformin in this child will actually lead to hypoglycemia because of a sudden lowering of insulin resistance. It will not give you a significant amount of weight loss. If at all you want to use something after 12, you'd better use something like topiramate. Definitely, I'm not a huge fan of metformin for obesity.
Thank you. You mentioned all the medicines and said all of them have no role. Thank you.
In a child,
so that brings us to Dr. Shreya. So no medications. Now this child who has come obese. Now what do we do with this child? Because there's nothing on the prescription. So what else can we do with this obese child in terms of managing the obesity?
So I think we're talking about exogenous obesity here. So we have already spoken about diet and lifestyle changes and exercise being a part of daily life. So apart from that, I think we do speak about intermittent fasting in adults. That generally we do talk about it a lot now. It's in all of the adult diabetics and adult obese patients that we see. But we also talk about this with the families of obese children, because it is possible to follow that sort of pattern where there's an early dinner which you can finish by 6 or 7 o'clock, or at least we can quote from our ancestors who used to eat by sunset, who used to eat the last meal of the day and finish that by sunset, and then explain about the circadian rhythm. So if there is some sort of consciousness around how food intake should be, and there's this term called mindful eating, that you chew slowly and you do not involve watching. You do not watch. There's no screen involved when you're eating, so that your entire focus is on the food. That also I think is important to talk about. Apart from what to eat and how much to eat, we also have to talk about when to eat and how to eat. And so then when they eat this way, the entire family, I think, becomes more conscious about what they're eating and how they're eating. And of course, it has to be a family effort, as we said, that the parents can't be doing something and then expecting the child to be doing something else. So when we say the child should not have when we say 5 to 1 0 rule, that rule stands for the entire family, I think. It's not just for the child, of course, that we all understand, that the entire family has to undergo that transformation. And generally, we also see this, that there's a lot of, it's like a pattern of obesity in the family, because it's always the exogenous obesity is majorly due to the habits that the family is following following every day, the daily routine that they follow. So when those habits change, it would be for the entire family. So probably eating early, the last meal of the day finishing early, and then sleeping early. The circadian rhythm, when we're speaking about, we speak about, of course, the timing of the food intake, and we talk about the time of sleep also. So early to bed and early to rise then becomes a very real concept. And if we can convince them about the scientific basis behind this and how the circadian rhythm will support, when they support the circadian rhythm, this rhythm itself will support them in losing weight. I think that's a very real sort of there's real science behind this. We all know about it. So that's another aspect of management that we can introduce to the family. And apart from what to eat, how much to exercise, I think everybody's tired of hearing that and nobody follows it. But if they can sort of get that time in place, the timing, of course, it's very difficult. How Dr. Nagesh and we all spoke about how the routine is set right now, and people are coming back, or even children are coming back home only at 9 from a grueling session of coaching or this and that, and they're all into competitive exams. And generally, it's this teen period which is very hard, and most of the girls are becoming obese and they develop PCOS, and then it's very hard to know how to counsel them because they're so engrossed in their studies and they are focused on the competitive exams at hand, that to talk about health is so tough. So that's a real challenge. But then we should make them aware, and we also, I think, should be role models for them in a way. We ourselves should, practice what we preach. That's the first thing. And as doctors, and then the family does it, and then the child does it. I
Yeah,
think
yeah.
this is
Thank you.
the
Yeah, thank you, Dr. Shreya. And one person who actually preaches and also practices this, especially with his son, is Dr. Shekhar. So Dr. Shekhar takes his son. I can't find him for any meeting on Sunday. And the reason he says is, I need to take my son for football coaching and also golf. So his son plays up to 3 to 4 sports. And as father to his son, Shekhar also plays all those sports. Dr. Shekhar, last words from you. How do you motivate? How do you get them into this groove beyond all the studies and beyond their regular lifestyle?
Hello. Yeah.
Yeah, go ahead.
The importance is not on for me. It is only fitness right now, and I am like as a fitness interest person. I'll definitely see today we are you and me here only because of your how you played your childhood. Okay, so the sports teaches you a lot, and the sports makes you a good person for the society. Definitely, that is the main reason for me to like make him active. Yeah.
I think this is a very important aspect. You might be able to study what is in a textbook. You might be able to write the correct answer in a question paper. But then there's life beyond it, and that's only the start point. You need to work as a team. Almost in every organization, you are part of a much larger group of people who are working towards a common goal. And to work as a team, you need to understand team dynamics, how to interact with each other, how to learn to handle failure, how to stay grounded when you're successful, how to consistently put effort. All this is taught when you play a sport. So if you are playing a sport yourself as an adult, that is the biggest motivation for your child. Your child sees what you do all day. What bigger role model than you for them? So please be the role model and please follow what you want them to do, and nothing bigger than that for the child. The child will eventually realize that he also wants to do what he is seeing his father or his mother do. And this has to become a part of your lifestyle. It doesn't help if you do it on a Sunday or just occasionally, just for the sake of motivating him. When you do it because you love doing it, that is when the child picks up and makes fitness as part of his everyday routine. And despite that grueling schedule that Dr. Shekhar mentioned, there's still another 12 hours that are left in the day. And we'll be probably able to sneak out a little time to invest our energies and our hard, precious time into a little fitness, even if it is for 30 minutes. Again, as per the AAP guidelines, 30 minutes a day should be enough for 5 days in a week to ensure that your health is taken care of. I think these are very important and very useful insights. I'll check if there are any questions on the YouTube chat. But before we conclude, I'd like to play a video that Dr. Vasant has specifically requested us to play. And this is on the launch of Disha. Disha is a motivational video and educational video which has been prepared by Indian Academy of Pediatrics. It's a very short 4-minute clip, and after that we'll close the session. And I'll take up if there are any questions that come up. Just a second.
Sri Krishna, volume is not there. Volume.
Yeah, let me now put it. I'm so sorry. Yeah.
Please
Just
start
confirm
again.
to me once. Yeah, I'll put it again. Just confirm to me if you can actually hear it. Okay.
Please.
1 second. Can you hear it now?
Yeah, volume is not there. You're able to see video, but
Are you not getting the volume?
not getting the volume.
No sound.
That's fine. Okay. So let me. I'm not very sure if. Okay. So let me just give one last try. Can you hear the sound now?
No.
Okay. I'm so sorry we're not able to play it, but I'll share it with everyone across the academy as well. It's a wonderful video that
Okay.
explains how we can motivate a child to take a U-turn with respect to their health. And thanks to Central IAP for giving us resources like this, which will help parents understand the importance of fitness and also mindful eating. Thank you all the panelists. Very interesting, very useful insights on a very common topic. I think this is bigger than any other infection that you see. In the coming days, you'll have more number of children being brought with the complaint of obesity than of infections. And it is important for us to know how to manage them. And the small nuances related to counseling, they will help you in addressing the parental concerns. Thank you, everyone. Any comments from Dr. Sridhar, Dr. Bhaskar, sir?
Only I request Sunkoj Bhaskar sir, our president, to give the closing remarks. Then RSV will close.
Yes. Yeah.
Sir. Sir, unmute, sir. Sunkoj sir, unmute. Bhaskar garu, unmute yourself, sir. So, I think some problem.
Sridhar sir, over to you.
Yeah, thank you, the panelists, well moderated by our none other than Sri Krishna RSV, and thanks Sri Nagesh and Shreya and Anjay sir and Shekhar, who had made today able to understand. I think this video will be there in the YouTube. I request all the doctors who can see on the YouTube, if they miss this direct link and other things, see, they can go and see the YouTube and update themselves. And sir, Sunkoj sir, can you give the closing remarks? Sunkoj Bhaskar sir, unmute yourself.
Yeah. Thank you, Dr. Sridhar. I really appreciate Dr. Sri Nagesh. We all know he's a genius endocrinologist from Telangana. Thank you, Dr. Sri Nagesh. We are looking forward for a few more academic activities.
Definitely.
For pediatric endocrinology.
Definitely, sir. I will.
Our another colleague, Dr. Shreya Sharma, all the way from Dehradun. Thank you, ma'am, for your lucid presentation. And Dr. Anjay, our fitness enthusiast, and as well a good shuttle player, marathon runner.
Thank you, sir.
And, really appreciate RSV had chosen all the fitness enthusiasts. And Dr. Shekhar is obsessed with fitness. RSV. And proudly, I say I am also a fitness enthusiast.
Yes. You are also.
Years.
Yes.
I think I am. So, sincerely, thank you, one and all. Jai.
Thank you.
Thank you.
Okay.
Thank you, everyone. Thank you.
RSV, close the things.
Yeah,
Okay?
yeah, yeah. That's all. I think you have already conveyed, sir. So thank you, everyone. Excellent panelists. I think it's all the content that makes the session so interesting. I'm sure there'll be more people asking about these points in the coming weekend, and it is up to us to stay as good role models. Who better than Dr. Anjay and Dr. Shekhar in IAP Telangana State as role models for pediatricians ourselves? For so many of us who are very busy and who are very proud that I have seen so many OP have stayed till midnight, etc., etc. Look at these two who are brand ambassadors of mindful eating, good healthy lifestyle, and also motivating their children to
Thank you,
follow
Sri Krishna.
lifestyle. Thank you.
Thank
And
you.
I hope the session changes our perspectives on childhood obesity and we can implement in practice and also ensure that we follow and not just practice but also preach and practice the same. Thank you, everyone.
And let us thank Dr. Sridhar. Sridhar is another sports person. He is our captain of cricket team who brought so many laurels to Telangana.
Thank
He
you,
is
sir.
another
Thank you, sir.
great sportsman. He is a
Thank you,
versatile
sir.
person, physically, mentally, organizationally, every aspect. Thank you, Sridhar. You are a great
Thank you,
asset
sir.
to
Thank
me
you so
and
much.
to Telangana.
Thank you.
Thank you, sir.
Thanks,
Yeah,
everyone.
thank
We'll catch
you.
up again at the
Nice.
next webinar. Thank you.
Bye.